Well, good afternoon, all. Continuing on in our spinal cord injury lecture series, today we're going to be discussing cardiovascular consequences of spinal cord injury. Maybe show me a thumbs up if you can hear me, if I'm not coming. Okay, thank you. We're going to be talking through the neurogenic consequences of spinal cord injury on cardiovascular function, and the influence that's going to have on several different aspects of care and management for spinal cord injury, including risks of venous thromboembolus, pulmonary embolism, including prophylaxis and management if those do occur. And then we'll talk through risk factors for coronary artery disease and peripheral arterial disease following spinal cord injury. So kind of as a starting point again, remember that the central nervous system is comprised of the brain and the cord. The cord, we typically assign levels of spinal cord injury based on the amount of function that's left, and that's based on the somatic nervous system. So basically, we have C3 through 5 contributing to voluntary control of the diaphragm, C5 to the elbow flexors, C6 to the wrist extensors, 7 to the elbow extensors, C8 to the finger flexors, and T1 to the finger adductors. Our intercostals and paraspinal muscles are served by roots from T2 through T8, and the abdominal muscles as well, T7 through T12, and then our hip flexors at L2, knee extensors L3, ankle dorsiflexors L4, L5 are the toe extensors, and the ankle plantar flexors. And so based on this, we have a fairly good understanding of what type of motor function and sensory function a person would have. However, we have to remember as well that the autonomic nervous system comes in and becomes integrated with the central nervous system at the thoracolumbar regions of the cords. So therein lies the beginning of the sympathetic nervous system. Recognize that it is opposed by the parasympathetic nervous system, which arises from cranial sacral neural axes. And so as we look at those two, there's a constant tug of war, and your body never actually shuts down either one or the other, but it increases the relative tone of one and it increases the relative tone of the other, depending upon the circumstances. So with regard to cardiac function, we have to recall that the cardiac plexus basically arises from T2 through T4, and then T5 through T11 supplies the celiac ganglion and subsequently the splanchnic vascular bed. So there's an awful lot of control over the autonomic nervous system with regard to the sympathetic nervous system, which again arises in the thoracolumbar regions of the cord. So these fibers within the sympathetic nervous system convey fight or flight, that is ergotropic responses. We mobilize stores, substrate stores, etc., to handle a crisis situation, either fight or flight. Again, this arises from the autonomic nervous system sympathetic components, and it is opposed by the parasympathetic nervous system components, which is more about conveying energy conservation. So after the fight or flight response, the parasympathetic nervous system, its relative influence increases, and you pay back all of those substrates and everything that was utilized during the crisis scenario. So basically, we're going to be paying back substrates that were utilized. We're going to see a reduction in heart rate, blood pressure because of vascular tone, etc. as we go through this. There is this entity that we've talked about just very recently called autonomic dysreflexia. And this is where you have a massive sympathetic outflow in response to a noxious stimuli below the level of the injury for folks who have complete or incomplete spinal cord injury lesions at T6 or above. And the complications of that include seizures, strokes, organ failure, and death, all of which are suboptimal. Those new to the spinal cord injury series maybe haven't heard that term yet. So recognize that a noxious stimuli below the level of the injury is going to influence particularly what we have happening above T6, if we cannot control T7 and T8, which contribute to the greater splanchnic nerve, we no longer have control over the splanchnic vascular bed, which is the largest vascular bed in the body. And therefore, we can't really have control over blood pressure responses. So a noxious stimuli below that level is going to stimulate splanchnic vasoconstriction, and we're going to see a rapid increase in blood pressure. The other thing that happens at around T7 and T8 is the nerve to the adrenal medulla. Remember, the adrenal medulla is also where you kick out all those additional catecholamines, epinephrine and norepinephrine. So those folks with injuries T6 and above, and sometimes T7, T8, we've talked about that, are going to result in a significant problem, and that occurs why? So you have a noxious stimuli. Typically, we think of a distended bladder. You or I, when our bladder distends, we feel it. If it's more than 400 cc's, it's all you can do to just hold control, maintain your sphincters until you can get to an appropriate place to relieve yourself. This is sensed by a person with spinal cord injury as a noxious stimuli. And in fact, that afferent information ascends the cord, but is blocked at the level of the spinal cord injury, and you get this reflex sympathetic outflow that causes splanchnic vasoconstriction and subsequently hypertension. The increased pressure is sensed by baroreceptors that send information to the medulla. The medulla sends information back to the heart to try to slow things down. And so we get a relative bradycardia, but below the level of the injury, we remain vasoconstricted. Above the level of the injury, we see vasodilation, sweating, and this pounding headache that we refer to as autonomic dysreflexia. So the autonomic influence on the cardiovascular system is profoundly changed after a spinal cord injury. Instead of having sympathetic activity going to the SA node, all you have is parasympathetic influence. And so instead of seeing an increase in heart rate at appropriate exercise, fight or flight types of situations, instead we see a relative bradycardia, a relative hypotension associated with this. And so when you look at these responses, we end up with a circulatory hypokinesis. On the arterial side of the heart and the vascular system, we have a reduced vasoconstriction, that is a relative vasodilation, and subsequently blood pressure drops. On the venous side, we also have a relative decrease or blunted sympathetic response. So you're not going to see venoconstriction, and in fact, you have venodilation. So the inferior vena cava, for example, at rest, each of your inferior vena cava holds about 500 cc's of blood. What? Yes, really, 500 cc's. And yet, after a spinal cord injury without sympathetic tone influencing it, your inferior vena cava dilates and is now holding approximately 2 liters of blood. And that 2 liters of blood, therefore, is not getting back up to the heart, so you have a diminished preload. And that's going to influence, remember the whole, what were those birds called? The starlings. Yes, the starling mechanism. So that if you reduce your preload, you reduce the relative contractility of the heart because you're not distending it. And so in response, if you decrease the afterload on the arterial side, that is the pressure that the heart is pushing against, that's reducing resistance. And with less resistance training, the heart will atrophy. If you reduce the preload as well, and you don't stretch it to cause contractility, you're also going to result in an adaptive myocardial atrophy. And so that's what we're dealing with. We're dealing with a person now whose heart muscle is atrophied and diminished in the face of what typically is seen as a reduction in afterload and preload. And then you also have on top of that a diminished chronotropic response. That is, you're not getting the sympathetic influence to the SA node, sinoatrial node. So it's rare that we will see a heart rate over 120 in somebody who has a T3 injury or above. And generally speaking, we see neurogenic bradycardia early on after the spinal cord injury, sometimes even requiring us to use transcutaneous pacing in order to manage that. We might also see dysrhythmias or a relative heart block. That wasn't there before because you had sympathetic tone impacting the sinoatrial node. So you have this neurogenic hypotension. Typically, we think about shock as being hypovolemic shock. So we have a reduction in the volume of blood. And in response, there's a compensatory tachycardia that typically we see. And that's kind of the mnemonic for hypovolemic shock. However, when you have neurogenic shock, recognize that you still get the hypotension, but now you can't activate the SA nodes. And so you can't have a compensatory tachycardia. And in fact, what's happening is you have parasympathetic influence via the vagus nerve to the SA node, and you have a relative bradycardia as everything slows down. So this is the scenario that we typically will see following traumatic spinal cord injury, where we have to deal with both hypovolemic shock, typically because of internal abdominal injuries, and neurogenic shock because of the spinal cord injury. And so this requires a very judicious management of the fluid administration early on after a spinal cord injury. So as the folks come to rehab, our first major task is to be able to get them to sit up without passing out. What? To be able to get to sit up without causing their blood pressure to drop so far that they pass out. And so we will use a gradual incline tilt table, for example. We'll use mechanical support. We'll use an abdominal binder to compress the abdominal organs against the inferior vena cava and squeeze more of the blood so the inferior vena cava isn't holding that whole 2 liters anymore. Compression garments to the lower extremities and make sure that folks are adequately hydrated. We kind of start off with salt tablets if their blood pressure remains low, and then we'll move on to other mechanisms. Typically, I'll go to Florinef and start off with 0.1 a day, or in some cases twice a day, and or use midodrine chloride, and then we can titrate the dose upwards to, and this is crazy for those of us in the medical field, but yes, we are trying to get the blood pressure up pharmacologically, not get the blood pressure down. Which is new and different for many folks who've not managed spinal cord injury before. We've also got this relative venous stasis in the lower extremities. So typically we have our muscle pumps that when you contract the muscles, it squeezes the blood upwards through the venous system, and you've got those valves in the veins that close and keep the blood from going back down. But if your lower extremity muscles are paralyzed because of a spinal cord injury, you're not going to be able to have that facilitated. And so you have this impaired muscle pump, a relative venodilation, again because of sympathetic blunting, and on top of that, ventilation is going to be diminished. So we will be talking about this soon, but basically without abdominal muscles and with a reduction in inspiratory muscle reserve, you can't take a deep inspiration. And that deep inspiration, go ahead for a moment, just deep breath, yes. When you do that, you create a vacuum within the thorax that also helps to bring the blood back up the inferior vena cava into the waiting heart. But that also is impaired after a spinal cord injury. And again, we're going to learn more about that in a couple of weeks as I talk about the respiratory system. So what else can go wrong? This is crazy, but almost immediately following spinal cord injury, there is a change in the factor 8C and the factor 8 antigen, and their relative change is such that you see an increased ratio. Ultimately, this increases clotting after a spinal cord injury, separate from the venous stasis. So for at least a couple of months following a spinal cord injury, this this change in our coagulability is something that we're going to have to contend with as well. And then obviously I talk about intimal injury to the vessels, and that can be any number of things, but typically related to fractures or venipuncture with traumatic spinal cord injury. And suddenly we're back to Virchow's triad. Back in 1856, Virchow described this, remember, as being a combination of venous stasis, hypercoagulability, and intimal injury. And when you have all three of those together, that puts you at high risk for venous thromboembolus or pulmonary embolus. So this clot, this thrombosis, basically, is going to attach to the endothelial wall of the deep veins, and other things that may be contributing to this. So women who have been on oral contraceptives and are smoking and then have a spinal cord injury on top of this, huge risk for VTE. As well, those women who get a spinal cord injury non-traumatic, but because of a tumor or cancer, that also increases their risk for hypercoagulability and VTE. Now, the signs and symptoms of a deep venous thrombosis, thigh or calf pain, unless you have a spinal cord injury, in which case you may not feel that. Lower extremity swelling, warmth, rubor and cords, and then a positive Homan sign. And so those of you who watch me on rounds in the morning, it seems like I move fairly quickly, but I'm always checking the lower extremities to see if there are cords, swelling, warmth, or rubor. And I do check for Homan sign as I'm going through there, which is basically passive dorsiflexion as you're squeezing the calf. You worry about post-phlebitic syndrome, especially for those folks who had an inferior vena cava filter placed and may have a tendency to clot anyway. Below the filter, they will continue to clot. And I've seen people gain over the course of 2 weeks up to 60 pounds, basically because of increased clotting in the lower extremities. So these are things that we all need to worry about early on. The bad thing about a VTE is that it can become a PE. So pulmonary embolus, remember this is a traveling clot that gets wedged in the pulmonary artery, and subsequently you can't oxygenate the blood coming through to the pulmonary vein. And so symptoms, you all know this: acute cough, maybe an ugly one, shortness of breath, chest pain, tachycardia, tachypnea, and then a syncope, cyanosis, restlessness, mental status changes. All of those put me, the hair on the back of my neck goes up, not because of autonomic dysreflexia, but because I'm worried about a PE. And so the differential diagnosis in that scenario would be pericarditis, myocardial infarction, and heart failure, all of which are bad things. And then particularly, and we've talked about this before, a PE or a myocardial infarction with somebody with a high spinal cord injury can rapidly cause autonomic dysreflexia and increase the afterload to a failing heart. So again, these are scenarios that we have to get on top of very quickly. The guidelines have changed a little bit over the years. In chest, basically 2016, they updated guidelines from before. I'm going to jump ahead though, because we also had the consortium guidelines that were updated in 2016, and basically DVT prophylaxis should include TEDHOs. What are TEDHOs? Thromboembolic deterrents. Do they? No, they don't. And I'll come back to that in a moment. So plus or minus TEDHOs, but definitely using pneumatic compression devices. Inferior vena cava filters are not recommended, let me say that one more time, not recommended as primary VTE prophylaxis in a person with spinal cord injury. And I'll come back to that in a few minutes. If there's no bleeding risk, then the first line prophylaxis is low molecular weight heparin. Typically we do 30 milligrams twice a day, and these are injections. Consider direct oral anticoagulants, DOACs. during the acute spinal cord injury, but still we prefer the low molecular weight heparin because it's more quickly changed. Adjusted dose unfractionated heparin is not recommended unless low molecular weight heparin is not available. And then oral vitamin K antagonist, that is warfarin or Coumadin, is not recommended in the early and acute settings. So if there's bleeding risk, assess that risk daily. Begin low molecular weight heparin as soon as possible. How long do we continue with prophylaxis? If the spinal cord injury is uncomplicated, either incomplete or complete, we say 2 months. If it's complete and there are additional risks, some of those things that I talked about previously, oral contraceptives, ideally we've stopped those. Cigarette smoking, ideally we've stopped that. But if that's not the case, then we're going to end up going 3 months as prophylaxis. So sequential compression devices. This goes all the way back to the very first volume of Lancet. In 1976, they had a really cool study listed in there where they used sequential compression devices on the upper extremities, and they prevented DVTs in the lower extremities. So it's not because you're pumping blood from the lower extremities, it's because you're compressing vessels and stimulating the release of antithrombin 3. So that's an important part of the clotting cascade you remember to prevent clots. There's really no literature to support the use of thromboembolic deterrent hose. Great marketing scheme, by the way. I should have gotten in on that back in the day, but really, I still use TEDs, but I use them to prevent shear injuries while I'm using the pneumatic compression devices or sequential compression devices. So we're going to use those pneumatic compression devices at least for the first 2 weeks. And again, the point of this is to increase antithrombin 3, not so much that you're expelling blood from the lower extremities. If the person has been appropriately chemically prophylaxed, when they come to rehab, we don't need to get a lower extremity Doppler ultrasound unless they are symptomatic and present with some of those signs and symptoms that I showed earlier. So the inferior vena cava filter, put together by Lazard Greenfield at University of Michigan. And while I was an attending physician there, Dr. Greenfield and I had multiple discussions about this. One of my concerns about its use was if you do quad coughing, and again, we'll talk about that when we talk about respiratory management of spinal cord injury. Quad coughing is essentially like a Heimlich maneuver to help a person clear secretions or cough who have paralyzed abdominal muscles. If you're doing that in the presence of a inferior vena cava filter, you can cause dislodgement, and that filter may migrate up and potentially through the inferior vena cava, leading to exsanguination and death, which are suboptimal. Yes. So if the person does have a filter, don't do quad coughing. If they don't have a filter, then think very, very strongly before putting one in if you think they may benefit from quad coughing in the future. So inferior vena cava filters are no longer indicated as a primary prophylaxis. But again, discussions with Dr. Greenfield while I was there, he was actually monitoring these over a course of years to see how much migration there was. And what they found is if they put the filter in the inferior vena cava above the level of the renal artery, then they found that it wouldn't migrate with the quad coughing. So if you're going to place it, at least place it high enough. Now we have removable filters, and that's even a better option. So these are the complications that can occur. Again, we don't want to put a filter in if we don't have to. Back in the day when I was a resident, back in your guys' shoes, the trauma surgeons were just slapping these in right and left because they didn't have to worry about bleeds, et cetera, et cetera. So, but now we know it's probably not the best thing to do, and we really do weigh pretty heavily if the person has a higher spinal cord injury, do they really need filter would they benefit? If they do need it, can we put it up above the level of the renal artery in the inferior vena cava? So anticoagulation prophylaxis, again, enoxaparin, Lovenox, 30 milligrams twice a day. David Chen out of what used to be RIC, the Research Institute of Chicago, is now the Shirley Ryan Ability Laboratories. They have used 40 milligrams sub-Q daily and feel that it's just about as effective as enoxaparin. Dalteparin is an option if you have to go to that, but it's much more expensive. Obviously, we have these alternatives if you develop heparin-induced thrombocytopenia, but again, fairly costly. Unfractionated heparin is not recommended. Back in my day, that's what we had. And yet now we know that the bleeding risk is significantly higher using heparin than it is using Lovenox or enoxaparin. So if you're going to use it, 5,000 units sub-Q twice daily, and then with complete spinal cord injury, adjust that dose. And then we had to monitor back in the day the APTTs. You don't do that anymore most of the time. Warfarin is not indicated unless a person has developed a PE. How do you know if they developed it? You work them up. So you look for the signs and symptoms that we discussed earlier, and then we move forward. Typically, we're going to do lower extremity venous ultrasound. And if you're thinking that this could be a pulmonary emboli, obviously getting arterial blood gas and a spiral CT are the way to go now. VQ scan used to be on the docket, not anymore. It's just not practical. And now that we have CTs as available as they are, it's much quicker and much safer to move forward with that. So I won't go into a VQ scan because you don't need to know it anymore. The management, if you do have a deep venous thrombosis, a venothromboembolus, and or PE, if the person is cancer-free, then the first line would be to use your direct oral anticoagulants. So again, the DOACs. Dabigatran, apixaban is one that we see used most commonly here. And you're going to choose these over vitamin K antagonists. And those are actually preferred over low molecular weight heparin for VTEs or PEs in persons who are cancer-free. If the person has a cancer, however, then you're going to be using the low molecular weight heparins. That would be your go-to, and or that would be better than your vitamin K antagonists, and that both of those would be better than your DOACs. But so then you're making decisions again. Usually the cancer-free folks are those that sustained a traumatic spinal cord injury, and the cancer ones are the ones who have developed a tumor and subsequently spinal cord injury because of that. So keep that in mind. The treatment period, if this is the first and there's no clear cause, 3 to 6 months. If you have a second VTE, then you're going to continue on through the lifetime. Or as hematology recommends, and they'll continue to work with us. You may need an inferior vena cava filter if you're high risk for pulmonary embolus. And again, you're going to weigh the cost benefit of that. If you do have to put it in, where are you going to go? Above the level of the renal artery in the inferior vena cava, obviously. So treatment for VTE or PE, enoxaparin, so Lovenox again, Q12 hours at 1 milligram per kilo or 1.5 milligrams per kilo per day sub-Q. Your daily dose shouldn't exceed, whichever you do, one dose or twice daily, shouldn't exceed 180 milligrams. Start warfarin therapy or Coumadin on day 1 and at 5 milligrams and adjust as necessary to get you there. Check the platelet count between days 3 and 5, and then stop your low molecular weight heparin after at least 4 to 5 days with combined therapy when your INR is greater than 2. We're shooting for a target between 2 and 3, so ideally 2.5. They hit 2.5 sometimes, but usually it's a little above, a little below. And we're going to use our anti-coag clinics to help continue to monitor this as we go through. So, how much time do I have left? I'm halfway through my talk. Heart disease. Heart disease is now the leading cause of mortality in chronic spinal cord injury. The problem is that it's often silent, particularly for higher levels of spinal cord injury. They don't feel angina the way that you or I would feel angina because of their spinal cord injury, and or, as we're going to talk about, the diabetes dysautonomia associated with that. So are they at high risk for diabetes? Yes, we'll get to that. So folks with spinal cord injury have a relative sedentary lifestyle, not by choice, but because this is what they're left with. Insulin resistance is generally high. Obesity is typically the cause of that insulin resistance, and it also contributes to the dyslipidemia typically associated with spinal cord injury. So what's the pathophysiology of atherosclerosis? So remember that you have some sort of damage to the arterial wall, exposing underlying connective tissue, and then you have an accumulation of platelets and monocytes getting in there to basically plug that damaged area. The platelets release platelet-derived growth factors that promotes smooth muscle proliferation in the area, and then subsequently you start to develop basically a scar, if you will, within the vessel itself. And that scar can take on more and more different types of debris, including calcium and whatnot, until essentially you've narrowed the lumen significantly, often more than 50% or more. And typically we think about this occurring in coronary vessels, but recognize that this is happening throughout the arterial tree. And so these folks are going to be at higher risk for strokes, higher risk for peripheral vascular disease as well. So let's talk about energy expenditure. Why? Because a person with spinal cord injury drops their energy expenditure by as much as 50%, after spinal cord injury. Not just because they can't use their muscles, those muscles atrophy. Muscles are metabolically active tissue and burn calories. And so as those muscles atrophy, your basal metabolic rate is going to drop. We'll talk through that a little bit more. Subsequently, the thermic effect of activity is also going to drop. So if I'm losing muscle mass and voluntarily can activate less muscle mass, I'm going to be burning fewer calories during any physical activity as we go along with that. We also know that upper extremity work, if that's what we're relegated to after a spinal cord injury, utilizes about 25% less energy than lower extremity work, despite similar rate pressure products. Rate pressure products, remember, are your heart rate times the systolic blood pressure. So at a similar heart rate, you're going to burn fewer calories using upper extremities than lower extremities. You've also got blunted sympathetic responses we've talked about earlier, and these are going to be contributing to hyperinsulinemia, impaired gluconeogenesis, and impaired lipolysis. But wait, that's not all. Your spinal cord injury also blunts anabolism, and relative to catabolism, you see a drop in testosterone and growth hormone levels, a relative increase in corticosteroids, and thyroxine, you develop a euthyroid syndrome. We can talk about that later. So you develop a positive energy balance. That sounds good, right? Except that it's not. What that means is we are accumulating calories at approximately 200 calories a day. If you take somebody whose energy expenditure is 2,240 kilocalories per day, but their energy intake is 2,440 kilocalories a day. I'm not a great math whiz, but that's a 200 calorie surplus. And over the course of a year, they're going to accumulate 73,000 kilocalories in the form of adipose tissue. That is about 20 pounds of fat. In the first year, they wouldn't even notice it because they're losing so much muscle and so much bone, because if you don't use it, you lose it. Yes, that's right, even though you're on mute. I can see your lips, so you're with me there. So let's talk about percent body fat. You and I, not too bad. You know, typically we're thinking for men, body fat is going to be less than 22%. But if it's over 22% and you're able-bodied, we call that obese, all right? I'm talking about percent body fat. I'm not talking about body mass index. Body mass index, typically for both men and women, if you have a body mass index of your weight over your height squared of greater than 25, we say you're overweight. If your body mass index is greater than 30, then we say you're obese. But if you have a spinal cord injury, folks accumulate much more fat and lose a lot more muscle and bone than they would have as an able-bodied individual. And so a BMI of 25 for a person with spinal cord injury correlates with 35% body fat. More than a third of their mass is fat. And so without beating this to death, they are literally swimming in fat. And we see about twice as much fat as we see in able-bodied individuals. And because of this, we see elevated pro-inflammatory cytokines. I'll talk about that in a moment. Increased clotting factors. And that increased fat mass actually contributes to coronary artery disease for multiple reasons. We know that adipocytes impair fibrinolysis. That means you increase TAFI and PI, those are sticky substances. Thrombin activatable fibrinolysis inhibitor, TAFI, and PI, plasminogen activator inhibitor. Both of these basically are going to impair fibrinolysis. That is, you increase your risk of thromboemboli as you have more body fat. We also know that adipocytes are pro-inflammatory. Dr. Farkas, who's on this Zoom, by the way, wrote a paper with me not long ago really talking through the different aspects of these pro-inflammatory cytokines secreted from fat and its adjacent tissue. And all of these pro-inflammatory cytokines are contributing to a number of different things that we're going to talk through, not the least of which is endothelial cell death, apoptosis. So we know that adipocytes cause hypertension. How do they do that? Adipocytes secrete, they are an endocrine organ, they secrete angiotensinogen, which is the potent precursor to angiotensin, and subsequently that contributes to vasoconstriction. So if they're secreting angiotensinogen, you're going to see ultimately vasoconstriction occurring. And we also know that they secrete interleukin-6, which basically decreases nitric oxide that usually contributes to relative vasodilation. So now you have a relative decrease in your dilation, that is, you have more vasoconstriction. You also have adrenal compression of this fat mass, particularly the visceral fat mass, which is going to interact with the whole renin, angiotensin, aldosterone system. And then as you're developing atherogenesis, the increased stiffness of those arteries are also going to contribute to hypertension. And so, wait a minute, Dr. Gator, you told me earlier that folks are going to have neurogenic hypotension, and they do immediately following their spinal cord injury. But as they accumulate fat mass over the course of months and years, then what we find is this unusual hypertension, unexpected hypertension, very tightly correlated with the degree of adiposity. So we've got that going against them as well. And we reported this in about 8,000 veterans way back in 2007. We were surprised to see the number of whom had blood pressures greater than 140/90, and it was not autonomic dysreflexia. What? So things are changing within the body of a person with spinal cord injury. We also know that visceral fat causes dyslipidemia. So you remember that cholesterol is all managed within the liver. And within the liver and the vascular tree, we have LDL, the low density lipoprotein, the bad cholesterol. And then we have the good cholesterol, high density lipoprotein that comes by and cleans up the vascular tree, you know, keeping everything, except that as you accumulate more and more fat around the liver, you increase the number of non-esterified fatty acids, and ultimately you increase LDL production and you decrease HDL production. And so you have less cleanup and a lot bigger mess happening because of the cholesterol changes at the liver as we go through that. And that, again, is related to visceral fat. And so there are a number of studies over the years that have demonstrated this. Basically, we're seeing that 2/3 of folks with spinal cord injury have HDL cholesterol, HDL cholesterol less than 40 milligrams percent. We see 44% of them have HDL cholesterol less than 35 milligrams percent, and 20% have HDL cholesterol under 30. That is, their garbage truck fleet, their cleanup crew has diminished because of visceral adiposity. And you're thinking, wow, that's really bad, but that's not all. Adipocytes also cause insulin cause. Did I mention cause? Insulin resistance. We know that they secrete these pro-inflammatory cytokines. Those are associated with insulin resistance. Not quite sure, at least in 2005, why that was the case. We did know that, however, as you accumulate fatty acyl-CoA, diacylglycerol, and ceramides within the cell, these are going to inhibit the PI3 kinase cascade. And so since that time, they've demonstrated about 8 different reasons why increased fat, and particularly visceral fat, 8 different reasons why fat impairs insulin signaling. That is, you develop insulin resistance. And so again, our folks with spinal cord injuries swimming in fat, and we do in fact find that they are at high risk for cardiometabolic disease. So it took us a number of years to put this together, but we finally got out the identification and management of cardiometabolic risk after spinal cord injury. And this was published in Journal of Spinal Cord Injury Medicine in 2019, essentially saying that this risk is due to obesity, pre-diabetes and/or diabetes, hypertension, and dyslipidemia. And the recommendations that we provided out of the guidelines had to do with nutrition, physical activity, and yes, pharmacotherapy. So how do you diagnose coronary artery disease? You all know this, and things have changed over the years. We used to do graded exercise testing. A lot of times now they do a dobutamine echocardiogram. We've found that exercise testing isn't as sensitive in persons with spinal cord injury, nor as specific as it is in the able-bodied population. And so more and more we're going to dobutamine echocardiograms to determine the degree, because most of these folks can't get up to a significant heart rate, as we talked about before. So to determine the degree of coronary occlusion. American College of Sports Medicine has new guidelines out in 2018, but they haven't changed much over the years, and basically they talk about risk factors, some of which can't be changed, some of which, including blood pressure, your lipid profiles, your fasting glucose, and your obesity levels can be changed. Major signs and symptoms that ACSM reports in able-bodied individuals include shortness of breath. Oh, our folks with spinal cord injury have that. Dizziness or syncope. Did I mention that as we're trying to get them to sit up for the first time? Ankle edema, lower extremity swelling because they don't have a muscle pump going, or unusual fatigue or shortness of breath with usual activities. So we don't know for sure if these symptoms in spinal cord injury are tied to heart disease or simply a result of the spinal cord injury itself. And so we do have testing recommendations for folks with spinal cord injury as we start talking about risk modifications. So those things we can't change, we can't change. We can change these, however. Smoking, hypertension, lipid profile, diabetes, and exercise. And so, unfortunately, I have found that it's still the case. Our folks with spinal cord injury have a greater incidence of smoking than non-spinal cord injured adults. What's up with that? And some people will say, well, it gives them something to do that they can do. But we really have to get them past this to the extent possible. So yes, we will counsel them with regard to giving up the smokes. We're going to have to manage the hypertension. Again, in spinal cord injury, determining if it's related to autonomic dysreflexia. But then the other thing is, what is a normal blood pressure for somebody with spinal cord injury? You know, in the acute setting, some of you that are helping manage my patients right now know that we have some folks who have spinal cord injury and neurogenic hypotension. In the acute setting, I'm just trying to get their blood pressure up. How high should I get it? And then as they accumulate body fat and their blood pressure goes up, when should I intervene? And at what level should I do that? And how should I do that? And so basically the recommendations are very similar to what we see in the able-bodied population. Basically beta blockers, nitrates to the extent necessary, calcium channel blockers, and ACE inhibitors can be used in sequence. And it's the same sequence that we would use with able-bodied individuals, but we're a little more cautious because we don't want to plummet their blood pressures. And we also don't want to mask autonomic dysreflexia. So, so that gets to be a little challenging. Lipid profiles. We would love to change diets in our folks with spinal cord injury, not just total calories, but the constellation of the diet itself may make a difference. And so we've recommended exercise and nutrition as listed here, but Mark Nash and I recently published, it just came out this month, a guideline basically for managing cardiometabolic disease in folks with spinal cord injury. And we do talk about the use of statins, and or the only real study that's been done in spinal cord injury is Dr. Nash's study using niaspan, long-acting niaspan. And so that's an option as well, but we can't just let it lie. We need to intervene. Similarly, with diabetes, we know that diabetes is going to contribute to a number of other problems as we go through there. As the person is demonstrated to have diabetes, we should appropriately intervene with metformin and or start thinking about the glucagon-like peptide 1 receptor agonists. And in fact, this recently, as we put forward the consortium guidelines, there was a lot of discussion out there on how do you manage diabetes, how do you determine if a person has diabetes, pre-diabetes after spinal cord injury, what's the right thing to do? And ultimately, I got to weigh in on this discussion literally and make the recommendations that, yes, we should treat these folks as able-bodied individuals and that failing to do so really does put them at increased risk for cardiometabolic disease. Exercise. I've got a whole separate lecture just on exercise, so I won't go into that here, but cardiovascular exercise as well as strength training exercise should be implemented. Measuring energy expenditure. Dr. Farkas has worked with me over the last couple of years, and we've been doing a lot to study determination of how many calories does a person with spinal cord injury need. And it's based on how many they're expending during the course of the day. And so indirect calorimetry really is what we need to determine that. The previously used equations and whatnot we've been demonstrating are not sufficient. And in fact, you can predict energy expenditure, but not, you're gonna have to modify what has been used to predict energy expenditure in spinal cord injury relative to those folks within the able-bodied population. And so just recently, we had put together this compensatory, there, I'm having a hard time saying it, a compensatory equation for folks with spinal cord injury. And this is based on some work that we had done and reported back in 2010 with Eileen Collins and Ed Langbein. Dr. Farkas has also recently worked with me to put together a review, a meta-analysis looking at nutritional status in spinal cord injury. And what we found over the course of looking at almost 300 studies and boiling them down, trimming them down literally to 12 in quantitative synthesis, that generally speaking, folks are still eating too much. Even those who seem to have fairly well-controlled diets. And based on what we are reporting and seeing reported in the literature, they would be gaining approximately 16 pounds of fat a year. 16 pounds of fat per year. So we have an ongoing study, my science project, Spinal Cord Injury, Exercise, Nutrition, Conceptual Engagement, where we are going to intervene with diet and exercise to the tune of 200 calories a day deficit over the course of 16 weeks to see if we can improve body fat, reduce fat mass, increase fat-free mass, improve insulin sensitivity and glucose effectiveness, improve lipid profiles, and reduce pro-inflammatory cytokines. So I do want to speak briefly about peripheral vascular disease. There's a number of folks that I worked with in the VA who subsequently developed gangrenous lower extremities, partly because of peripheral arterial disease that was not picked up in time. And they subsequently had to have amputations. When they amputated the lower extremities, it changed their pressure mapping, or at least the pressure that wasn't mapped, and put them at higher risk for pressure injuries. Whole separate lectures on that as we go through there. So recognize that our folks are at higher risk for peripheral vascular disease, and they may not experience it. This is one of those scenarios where a person with AISD tetraplegia, for example, may be walking, and then they have lower extremity pain, or not. They just get autonomic dysreflexia because of it. And it's because of peripheral arterial disease that we wouldn't have picked up otherwise, which is a noxious stimuli below the level of the injury, subsequently causing autonomic dysreflexia. So medical management of peripheral vascular disease in spinal cord injury is the same as that in able-bodied individuals. Revascularize the lower extremities when we can. Try to prevent amputation because it really does change the pressure dynamics in the seating systems and puts them at high risk for pressure injuries as we go through there. And then finally, I have a whole separate lecture just on aging after spinal cord injury. Why do all of us age? I was in California for a while, in Ann Arbor, Michigan for a while, talk about free radicals. No. Free radicals are released from cells under conditions of increased inflammation and hypoxia. And so this combination of things we know will contribute to essentially mitochondrial death over time. And so cellular aging is related to aging mitochondria, a reduction in oxidative phosphorylation, a decreased ability to repair structural and enzymatic proteins. And subsequently, we see spinal cord injury as a model for accelerated aging because of these things. And so there are numerous case studies that you can look out at, but one of them that was fairly well publicized is that of Christopher Reeve. And his change over 18 years doesn't look all that great here, but then over the next 8 years, you can see a significant change in the way that he aged, and this was just prior to his death, unfortunately. So I think that just about takes up my time. I'm fortunate to have had funding over the years, and we've got a number of references available to you. If you want these slides in PDF format, let me know. I'd be happy to send those to you. My email is dgator@miami.edu. But now I can take a couple of minutes for questions, if there are questions. feel free.
Dr. Gator, I have a question.
Yes.
Assuming an SCI person is otherwise healthy with no diabetes and CVD, what is the target level for LDL for them?
Well, we're still going to be shooting at the usual, the same that you'd see in the able-bodied population.
Okay.
So 100 milligrams percent is typically what we would look at. And again, usually it's not the LDL cholesterol that is bad with these folks, it's the HDL cholesterol.
HDL is too low?
Right.
Okay. Thank you.
You bet. I'm assuming that was Dr. Tiazzo, one
Yes.
of our exercise physiologists on the call. Any other questions, thoughts, concerns? There will be an upcoming lecture just on metabolic dysfunction after spinal cord injury because, I don't feel like I had enough time to really express all of the things that we found over the last couple of decades in that area. All righty, hearing no more questions, feel free to email me if you're just shy. And again, if you'd like a copy of this, this lecture, shoot me an email, DGATER, not OR, I'm not a cold-blooded reptile, you guys know that, dgator@miami.edu. All right, and everybody have a wonderful day. I hope your day continues to get better and better. And mine as well. Thanks all. Let's see if I can actually turn this off. Stop sharing.